There are many ways data can be interpreted. Patients want relevant information they can understand, and healthcare professionals want to be able to communicate this information effectively. One way to explain the effect size of an intervention is to use number needed to treat. It is a useful way to relate study results back to real-world clinical practice. Let's look at an example. A meta-analysis of antidepressant drug that is used to treat pediatric patients showed that the medication had a response rate of 60%. Great, 6 out of 10 children improved their condition because of this medication. But wait, if we look further into the study, the control group receiving the placebo had a 49% rate of improvement. This is important to consider, as this means 49% of children taking the medication would have likely improved themselves anyway because of the placebo effect or regression to the mean. One way to analyse these results is to use the number needed to treat. NNT describes the unique contribution the intervention is having towards the outcome. It tells us how many patients must receive a treatment for one extra patient to experience the outcome. It is calculated as the inverse of the absolute risk reduction, or 1 divided by the experimental event rate minus the control event rate. So, to analyse this study, we divide 1 by 60% of children who experienced an improvement minus 49% who improved in the placebo group. This is 1 divided by 11, or 1 child in 9.1. NNTs are always rounded up to the next whole number as to not exaggerate the effect or make the result look more optimistic. Therefore, the NNT for these children would be 1 patient in every 10 needing to be treated to experience an improvement because of the medication. Facts about number needed to treat. The lower the number of the NNT, the more effect the intervention has. NNT is able to compare an intervention to another intervention or a placebo, though when 2 active drugs are compared, the NNT will be much higher than if a drug is compared to a placebo. The NNT is time-dependent. The longer a clinical trial is conducted, the more likely the chance of the condition to respond, resulting in a smaller NNT. Also, the longer a patient is taking a medication, the more likely they are to respond. An example of this is an antidepressant having an NNT of 79 after 1 week of patients taking the meds versus an NNT of 6 after 9 weeks. Healthcare professionals and patients need to consider the study criteria when assessing NNT. The participants in a study may be different from the patients being treated. For example, if a patient being treated is healthier than the study participant, the NNT would be lower. Conversely, a patient's condition is more severe, the NNT would be higher. The baseline risk or the severity of the condition is another consideration. Take blood pressure, for example. The NNT to prevent 1 death, stroke, or myocardial infarction in a 5-year period has an NNT of 141 for mild hypertension, but has an NNT of 3 for severe hypertension. NNT is better at describing dichotomous data, but it can be used to look at scores on a continuous scale. A condition like pain can be analysed by establishing cutoff points, like comparing moderate to severe pain versus mild to none. NNT assists healthcare professionals when evaluating the cost, side effects, treatment impacts, or resources available. Minor conditions might not be treated if the costs and side effects of an intervention are high, even if it has a low NNT, whereas serious illness may still be treated even if it has a high NNT if the costs are low and the side effects are minimal. NNT can be a useful clinical tool for patients and healthcare professionals alike, helping to judge if an intervention is worthwhile.
Created using Powtoon.